With our second presentation for the day. It is my great pleasure to introduce Dr. Leila Khan. Dr. Khan did her medical school from University of Maryland, then went on to do an internal medicine and chief residency at the Penn State Hershey Medical Center, and then moved on to University of Pittsburgh for her endocrine fellowship. Other than being the co-director of the Calcium and the Parathyroid Center, Dr. Khan is a very valued member of our endocrine women tribe. I'm sure all of you have been the recipient of her collegiality and warmth. And it is my pleasure that she'll be presenting to us today. Dr. Khan, please.
Thank you so much, Dr. Makin, for your warm introduction. Good morning, everybody, and I appreciate the invitation to speak today. Can everyone hear me?
Yes.
So I wanted to start by discussing the effects of fractures. So a fracture due to osteoporosis occurs every 3 seconds around the world. It results in substantial morbidity, mortality, and there's a huge societal cost. Osteoporosis is one of the greatest threats to the health of older adults. And it was used to be considered an inevitable part of aging, and with the clinical significance of these fractures. So for the fellows, what is a fragility fracture? So it is a fracture that results from a fall of standing height or lower with minimal trauma. So although it may be icy in a few weeks or months here in Cleveland, even if one slips on the ice and falls, it is considered an osteoporosis fracture. It's often a sentinel event related to low bone mass caused by underlying osteopenia or osteoporosis. And someone who has a fracture is twice as likely to have a second fracture. The scope of the problem is enormous. By age 50, for the remaining lifetime of the population, half of women and 1/5 of men will experience a fracture. Worldwide, osteoporosis causes more than 8.9 million fractures annually. And interestingly enough, the greatest number of osteoporotic fractures occurs in Europe at 35%. In 2011, 39 million Americans are more than 65 years of age, and in 2050, there'll be approximately 88 million Americans more than 65 years of age. Currently, there are 2 million fractures in the United States annually, but this is projected to increase to 3 million by 2025, or 5 years from now. Fractures can be followed by a full recovery, or they can be chronic pain, disability, and death. Only 40% of individuals fully regain their pre-fracture level of independence. Economically, this has very high cost. A conservative estimate has placed hip fracture among the top 10 most costly admissions. 1990, in the United States, the annual cost was about almost $35 billion, and it's projected to increase to $131.5 billion by 2050. And just to give some context of the price of these hip fracture admissions, for admission, this was approximately $18,000, acute myocardial infarction about $18,000, acute cerebral vascular events about $15,000. And these are conservative estimates. Unfortunately, we have very miserable statistics on the diagnosis and treatment of osteoporosis. This is not only in the United States, but worldwide. People, despite fracturing, are not getting their bone density scans, not getting their suggested lab workup. They're not even getting started on calcium and vitamin D, biological therapy, and they're not getting fall assessments. Even at our esteemed institution, the testing and treatment pre and post fracture admissions are poor. This is some data that was done by Dr. Maria McCloskey and myself. It's based on a chart review from from main campus of Cleveland Clinic patients, 100 patients in total, ranging from 2015 to 2018. There are 32 surgeons represented from the data, and despite fracturing, patients did not get any bone density or treatment within 2 years. So DEXA prior to fracture, 65% of patients did not have any type of imaging test done, no treatment done before the fracture. But even after the fracture, with that 2-year window, still 73% of people never received any bone density test, and 72% did not get any treatment for their osteoporosis. So even at our highly ranked institution, the statistics are poor for treatment of this condition. So there are a lot of options for treatment of osteoporosis. Which guidelines should one use? There are actually 52 national guidelines from 36 countries. I thought in this update of osteoporosis, I would discuss the guidelines that came out for the management of postmenopausal women from 2019. It was published in JCEM last year. I felt that they have very nice evidence-based approaches, and they looked at 107 randomized controlled trials to look at the outcomes of this data. And then they also did a second review of the data, which evaluated values and preferences of treatment, which I think is an important clinical point. So they have a very nice updated algorithm for the management of postmenopausal osteoporosis. I'm going to take you step by step through this algorithm. The first thing that I wanted to point out is that they use a FRAX score as part of their risk stratification. Based on their risk stratification using the FRAX score and other factors, they placed postmenopausal women in low, moderate, high, or very high risk groups. For the fellows, what is a FRAX score? The FRAX score is a clinical tool that helps predict patients who may fracture, typically used in patients with a diagnosis of osteopenia. It is country specific, and so you have to use the data from a specific area of the globe.
Does it give a choice like US,
Yes,
African
it does.
American, US, Asian?
So unfortunately, yes, it does. But you know, the data isn't as robust sometimes for non-Caucasians. I don't know if you want to add anything, Dr. Williams.
Yeah, thank you. The FRAX score has been out actually for a number of years, and they've validated in other ethnic groups and also internationally. So yes, you're absolutely right. You can drop down the menu and make sure you're identifying not only the country, but the specific ethnicity.
It's by no means comprehensive. I mean, these are the only factors that are taken into account, but it's just a kind of a nice starting point or a nice reference to kind of help risk stratify. And you know, the percentages which are significant are more than 3% if you have a 10-year hip fracture, or more than 20% for a 10-year major clinical fracture. These are the cutoffs that are significant, 3 and 10%.
Yeah, those are the treatment thresholds established by the National Osteoporosis Foundation.
So this very busy slide goes to show that you can have low, moderate, high risk based on three risk groups: prior hip spine fractures, the BMD at the hip and spine, and your FRAX score. And basically those 3 points help risk stratify your population. Back to the algorithm, I did want to discuss, so there are anti-resorptive drugs which suppress osteoclastic bone breakdown, and also there are anabolic drugs which promote new bone formation. And the first drug I wanted to discuss is the newest kid on the block, or Romosozumab, which came out in 2019. So Romosozumab was noted, sclerostin became a therapeutic target for osteoporosis after it was noted that individuals with sclerostin deficiency have high bone mass and resistance to fractures. So in 2001, there was a note that those individuals with sclerostosis, a rare genetic disorder, had these findings. And sclerostin became a therapeutic target of osteoporosis treatment. It's a monoclonal antibody, and it actually does two things: increases bone formation and decreases bone resorption. It's given monthly in doses of 210 milligrams, and it's a this bone forming effect occurs, wanes after 12 doses. So no more than 12 doses should be used. So that's why the indication of treatment is for 1 year. And after the treatment of these monthly doses of Romosozumab, one should change these individuals to bisphosphonates or denosumab. The other name for Romosozumab is Vinni. So the first main study that I wanted to review about Romosozumab is FRAME. And this was from Felisa Kosman and her colleagues, and it was published in the New England Journal in 2016. International randomized double-blind placebo-controlled trial, phase 3 study, very large group, more than 7,000 women. The osteoporosis that these women had with very low T-scores, -3 to -5. The individuals are randomized according to their age, less than 75 and more than 75, and also prevalent vertebral fractures with a yes or a no. And they got these injections of the Romo or placebo for the first year, and then followed by denosumab for the second year.
Leila, can I interrupt you?
Yes.
Dr. Lakara, do you have a comment? He's having trouble logging in. Dr. Lakara, you will have to unmute yourself.
I can get my phone if he needs to.
Is this working?
Yes.
Okay, let me talk at the end. Let Leila keep on going. This is a great lecture.
Thank you.
So the FRAME study, showed significantly reduced incidence of vertebral fractures in the group that received Romosozumab followed by denosumab, as compared to the group that got placebo for 1 year and then denosumab. So the risk of vertebral fractures was 0.5 in the Romo group and 1.8 in the placebo group. So there was significant risk reduction. And actually, there was extension of the FRAME study, and it was seen that this significant reduction was maintained in vertebral fracture. There was also continuation of the spine and hip BMD increases at 36 months. It was not, I wanted to say that this study was not powered for hip fractures. The second study that I wanted to discuss is called ARCH. This is active controlled fracture study in postmenopausal women with osteoporosis. Again, large group of women, very high risk, who are very high risk of fracture. They received 1 year of treatment with Romo plus 1 year of alendronate or 2 years of alendronate, the bisphosphonate. And again, there was marked reduction of vertebral fractures at 24 months with the Romo group, and also reduced incidence of hip fractures and also non-vertebral fractures. The issue with ARCH, which I wanted to bring up today, is that there were some cardiovascular adverse events which occurred in the Romo group. This was all in the appendix. They were detailed of which events these were, but basically 50 people in the Romo group versus 38 in the alendronate group had serious cardiovascular adverse events. And I do want to mention that in the study that I just reviewed, the FRAME trial, there was no increase in cardiovascular disease. But in the ARCH group, there was. And it was hypothesized that the role of sclerostin in aortic vascular smooth muscle, maybe to account for this. And a result of this finding, there isn't a warning about Vinni or Romosozumab, which is that you really can't, people at high risk of heart attack, stroke, or death, there's a warning about this.
Is there a contraindication to saying, like, if the patient had a previous MI or stroke, let's say in the last year or two, it's contraindication?
Yes, there is. And actually, the contraindication is for individuals who had it for the past year. So, it kind of makes me concerned about starting someone, if they had a cardiovascular event like a year and a half ago, is it safe to use? I mean, it's a little bit, the water is muddy. So shifting gears to the next treatment of bisphosphonates, going back to our algorithm, these bisphosphonate drugs have dominated the landscape of osteoporosis therapies for the last 2 decades. I think everyone knows that. And these are approved for the treatment of postmenopausal osteoporosis, glucocorticoid-induced osteoporosis, and male osteoporosis, or osteoporosis in males. And just to give you a sense of how commonly these prescriptions were given, between 2005 and 2009, there were 150 million prescriptions in the United States dispensed for the oral bisphosphonates. But as time has gone on, there have been concerns about the cumulative effects of bisphosphonates on our patients. They have very good risk reduction of vertebral fractures, hip fractures, and non-vertebral fractures. These are statistics from the JCNM analysis of the randomized controlled trials, but they're very consistent with other studies which have looked at bisphosphonates.
Leila, we have a question in the
Yes.
chat. Is the monthly Romo given in clinic or at home?
A clinic. And that's another barrier to the treatment because you have to arrange for the administrations in clinic every month.
Are there any side effects associated with it? Is it an infusion or is it a shot?
So, I'm embarrassed to say that I actually have never prescribed it.
It is an injection.
Yeah.
But it is a 2-step process. The biggest challenges that I know I've run into is exactly what you identified. These are older patients. And so the cardiovascular risk, trying to establish that clearly, and then getting it ordered, and then getting it as close to home as we can so the patients are compliant.
So they can do the shot at home. It has to be done in the clinic. Are they watched, like sometimes you can have a flu-like syndrome after a reclass infusion? Is there anything like this that is expected?
With all of these injections, there can be an acute phase reaction, and they can have flu-like or achiness, sometimes even mild fever. We instruct our patients to call us and be in close contact with us, and I follow them very closely.
And looking at the common side effects, joint pain, headaches, there is mention of possible hypocalcemia from the package inserts, and they do suggest severe jawbone problems can occur, but I don't actually know how frequent those side effects, that side effect is.
Okay. For those of you who want to prescribe Romo, please remember that it's in the clinic shot. It's not at home. So the patient has to be ready to come in.
Yes, every month. So any other questions about Romosozumab? Okay, so going back to the bisphosphonates, the main issue has been this cumulative effect of bisphosphonates. And it was first noted by dentists and ENT physicians, I believe, in about 2003 that there's osteonecrosis of the jaw with bisphosphonates and also atypical femur fractures. This was noted to be occurring from cumulative exposures to bisphosphonates in 2007. When I was at ASBMR a couple of years ago, the incidence is extremely low, and the speaker, I'm forgetting who it was exactly, but said, it's similar to getting struck by lightning. So although, there's very prevalent discussion of these perceived risks in the media, and these risks have gotten wide coverage in the media, and there's a high concern of these perceived risks by the public. It's really probably out of proportion to the absolute risk. But that being said, These are issues that one has to consider, and this osteonecrosis of the jaw and atypical femur fracture, and that is why risk is really needed to be reassessed at 3 to 5 years of treatment, and there's now a notion of a drug holiday with these bisphosphonate drugs.
So the American Dental Association and the National Osteoporosis Foundation actually came together, I think it was in 2011,
Yes.
and wrote an article together. And their conclusion was, because of the increased risk, possible risk of fracture, that the treatment really should continue. I think it was Dr. Mike Lewicki who actually looked at the risk and said you're more likely to be struck by lightning.
It's an interesting thought. Fortunately or unfortunately, this is still likely to be an ESAT question. So
Yes.
regardless of the very low incidence. Go ahead.
The thing about bisphosphonates, you can have the effect of the treatment after 5 years, but in 2 long-term studies, there is good evidence for long-term bisphosphonate use. But that being said, there is this notion of a drug holiday, particularly because these negative, these side effects of the atypical femur fractures and the ONJ seem to kind of diminish after the drug is stopped. And so I just wanted to discuss FLEX and discuss Horizon briefly. But these were both 2 moderate-sized randomized placebo-controlled trials, large studies, each of them more than 1,000 women who had long-term use of bisphosphonates. For the FLEX group, it was alendronate. So it was 10 years of alendronate versus 5 years of alendronate followed by placebo. And for the Horizon study, it was 3 years of zoledronic acid versus 6 years of zoledronic acid. So the 3 years group had then placebo, and then versus the 6 years. And basically, there is reduction of the gains in the FLEX study. The vertebral risk was much lower in the group that continued on treatment, but there was no reduction in non-vertebral or hip fractures in the group that got placebo. In the Horizon group, the BMD fell more slowly. Markers seemed to rise more slowly in this group, but the group that continued on had lower risk of vertebral fractures, although no significant effects on non-vertebral fractures. So I think just like any aspect of medicine, it's important to have an open conversation with your patient. You need to really individualize your treatment. You can definitely want to consider a pause in therapy, and you may want to do a drug holiday after 3 to 5 years of treatment, depending on their overall risk.
Leila, would you consider stopping the bisphosphonate and moving them to something else?
Yes, I would consider then changing it to denosumab.
Agreed.
And that's a great segue to the next drug, which is denosumab. This is a anti-rank ligand monoclonal antibody. It's given every 6 months in the clinic. The reason is that it has to be given in the clinic, again, stems from issues with insurance. And so for those individuals, who use insurance, which is pretty much mostly everyone we see, they really need to get this in the clinic every 6 months. It's a nice alternative initial treatment for women with a high risk of fracture. It's very important that if it's stopped, you really need to change treatment to another drug, because there's a rebound in bone turnover immediately after the drug is stopped. It's given every 6 months. So after 6 months after your dose, you need to really make sure to give that second dose or continue with treatment or change it over, because there's a high risk of vertebral fracture. The seminal study was Freedom's trial, which looked at vertebral fractures, hip fractures, and non-vertebral fractures. And this came out in the New England Journal of Medicine in 2009 by Cumming et al. And very high-risk patients, the T-score was -2.5 to 4. It was 8,000 patients. Their age was 60 to 90 years of age. 36 months, they got the denosumab 60 milligram dose every 6 months. And the primary endpoint was a new vertebral fracture, which was markedly reduced in the group that received denosumab. And the second endpoint was non-vertebral or hip fracture, and this was also significantly reduced. There is an extension of this study for 7 years, and I think the main issue with denosumab is really how long to treat. There's no notion of a drug holiday with denosumab because of this rebound risk of vertebral fractures with stopping it. I do want to mention that there's a nice niche for this drug for people who have impaired kidney function, and this drug can really help. But for anyone with CKD or malabsorption, you have to be exceedingly cautious about hypocalcemia. And I think it is now the standard of care to check the calcium, magnesium, phosphorus within 14 days of injection of this drug to make sure that they are very low risk for hypocalcemia. I have had patients who have significant malabsorption associated with intestinal failure, have severe hypocalcemia, and then unfortunately need a hospitalization of, sometimes up to 5 days for the low calcium.
I think I would like to mention here that last time I was on service with one of the fellows, we actually saw a case who had gotten denosumab about 2 months prior and had either an intestinal transplant or some kind of malabsorption because of surgery. And we saw the low calcium still persistent because of that denosumab infusion. I believe I had called Dr. Khan because I wouldn't believe that denosumab can cause this much hypocalcemia for this long, but she did mention that we can see these cases as well.
Yes, I did see someone with a similar presentation too.
Yeah, I have also seen a patient happened to be on TPN for short gut with a number of issues, and of course you can imagine the bone issues. But unfortunately was given the denosumab in another department, and then she presents to me and she was actually symptomatic. So this is the real deal. At the minimum, make sure you know what's going on with the calcium and the D.
There was a study in 2016 by Miller et al. JCNM, which looked at zoledronic acid versus denosumab. And the zoledronic acid dose was actually every 6 months, interestingly enough. It was more frequent than what typically is given for osteoporosis. But in a comparison of these drugs, there was increased BMD with the denosumab as compared to zoledronic acid. I mean, the strengths of the study were they were robust study size, low dropout rate, but it was short follow-up. And the adverse events were really, really quite low. 2 atypical fractures in the denosumab, and 1 ONJ in the zoledronic acid group. But there was bone turnover markers are also decreased in denosumab, but this is the data showing lower rate of fractures in the increased BMD from baseline in the gray group, which is the denosumab group. So the BMD increased, and the markers were much lower in denosumab. But just keep in mind when you're deciding among zoledronic acid versus denosumab, the denosumab, like I already mentioned needs to be given every 6 months. Pretty much, I would say, for the next 10 years, if not longer. So you have to consider that when you decide to treat them. So shifting gears to teriparatide and abaloparatide, these are the older anabolic treatments. The teriparatide and abaloparatide both bind to the PTH1 receptor. The teriparatide was approved in 2002, the abaloparatide more recently in 2017. So teriparatide PTH and abaloparatide PTHRP, or PTH-related protein analog. Basically, again, for the fellows, a take-home point, with continuous exposure to PTH and PTHRP, there is increased bone resorption. But if you can give it intermittently, both of these drugs do lead to enhanced bone formation and can cause anabolic effects on the bone. It's not 100% clear why the continuous versus intermittent exposure to these drugs cause bone, but they do, and these are nice drugs. So the indications for anabolic treatment, definitely severe osteoporosis, those high risk for fractures, people who have failed alternate therapy, who have other intolerances to the other drugs, or steroid-induced osteoporosis. And I do want to mention that there is now ongoing work in the Spine Institute to look at the teriparatide and see if it helps with bone healing in the setting of a spinal fusion surgery. And this is an interesting area of research. So the thing is, there's this really theoretical risk of osteosarcoma with these drugs. It basically, in Fisher rats, there's a higher proportion of those rats that got osteosarcoma with higher doses of PTH 1-34 or teriparatide. The dose that these rats got were really 4 to 28 times human exposure, and the osteosarcoma risk seems to be dose dependent. But nevertheless, there is this black box warning about the drug, and it carried over to the abaloparatide. I mean, when you look at the data about osteosarcoma in humans, there have been only 3 cases to date, which is really the same rate as the general population. But unfortunately, this osteosarcoma black box warning has really carried over to the drugs. You can have hypercalcemia, you can have hypercalciuria with these drugs. They both, and also with the abaloparatide, I do want to note there you can have headaches, dizziness, nausea. Unfortunately, in the past week, I think I've had 3 people, I don't know if it was just a fluke week, but who've had really bad intolerances to abaloparatide. That's been a little bit disappointing. You know, these have significant risk reduction of vertebral fractures, non-vertebral fractures. The seminal paper was from New England Journal in 2001, Near et al., which showed how the teriparatide really improved your risk reduction. Abaloparatide also causes similar risk reduction. It's not approved, I do want to mention, by the FDA for men to get abaloparatide for their osteoporosis. It's also not approved for steroid-induced osteoporosis.
What are the best options for glucocorticoid-induced osteoporosis?
You know, I think teriparatide would be an excellent choice, denosumab, bisphosphonates. And I think abaloparatide is also an excellent choice. It's just the data hasn't come about yet. I don't know if you want to add to that.
No, it's, yeah, the bisphosphonates really have the most robust data when it comes to glucocorticoids induced bone loss, and also in men. But I agree, Leila. I think that it's just that the data is behind. But these are both, they're very efficacious drugs.
You know, I think the sequence of drugs is important to mention. In the Vero study, people who received teriparatide before the bisphosphonate treatment seem to have a much more reduction in their vertebral risk. And it's important that the teriparatide is started first versus bisphosphonate followed by the anabolic treatment. The Vero study is a vertebral fracture treatment comparison in osteoporotic women, in women who have very high risk of fractures. So basically, teriparatide exposure to bisphosphonates is associated with transient decrease in BMD. And so, you know, the hypothesis has been that there's just too much breakdown if you give the bisphosphonate or the denosumab first. You really want to give the anabolic treatment initially, if possible. And this can be a very helpful, persuasive thought for those, you know, insurance companies who don't want to pay for this anabolic treatment.
That has been the #1 barrier, is that they are still stuck on requiring a bisphosphonate first and then prove failure, which I think is a travesty.
And when you look at other comparison of anabolic drugs, so the first study by Langer et al. Compared Romo versus teriparatide, and Romo did have better data with increased changes in BMD in the hip, femoral neck, lumbar spine at 6 and 12 months compared to teriparatide. Both groups had already received bisphosphonates. The active trial was looking at abaloparatide versus teriparatide and versus placebo, and it showed greater improvements in BMD with abaloparatide than teriparatide at 6, 12, 18 months at the total hip and femoral neck. At the lumbar spine, it was initially shown to be improvements were shown, but at 6 and 12 months, but not at 18 months.
Leila, we have a question.
Oh, yes.
Dr. Sangeeta Kashyap says, excellent and informative talk. What do you suggest for hypogonadal men with prostate cancer-related bone loss?
So, despite the warnings of so hypogonadal bone loss in men, I mean, you could definitely consider testosterone. And if they have a history of prostate cancer causing their hypogonadism, sometimes I often speak to the urologist, and oftentimes they will give clearance for the testosterone. So if their hypogonadism is from prostate surgery, that's an option. And then you can also use, I think, use any of these treatments really, although you have to keep in mind the FDA indication.
That's what I was going to ask. Is there specifically something that's FDA indicated?
So the bisphosphonates are used, and the teriparatide is used.
Can you use denosumab?
So I don't believe you can use denosumab, but I would want to verify that.
Okay.
I agree.
Yeah, I don't think that you can use it at this point. But the thing is, that you could have a discussion with your patient, and if it's felt that denosumab is the best option for these individuals, I think it would be appropriate to consider it all, but just to let them know that it's maybe not FDA approved.
My concern always with teriparatide is the fact that it is a daily shot.
Yes.
So some of them might not be adherent to it. So
Yes,
compliance
right.
always comes into the picture, while denosumab being every 6 months, compliance is going to be easy.
Yes, teriparatide also, please remind your patients it has to be refrigerated. If you keep teriparatide at room temperature, it doesn't work. The abaloparatide can be kept at room temperature, so for those who may be traveling, that's a nice alternative. And I sometimes have chosen treatment based on how often they are on an airplane.
Okay. All right, that's good to know. Oh, for the audience, that is important.
So after 2 years of anabolic treatment, most of the effects wear off. Don't just stop the drug, follow up with another agent. Just for completion's sake, I did want to mention other treatments. So you can have the SERMs. You absolutely need to use these who have individuals with a low risk of DVT, because these drugs can result in DVTs. They're a nice niche for those who may be at high risk of breast cancer. The hormone replacement treatment is very helpful for those who may have bothersome postmenopausal symptoms, but you do want to ask them about history of myocardial infarction, stroke, breast cancer. You don't want to give them to people who have been out of menopause for more than 10 years. You want to give them to people who are less than 60 years of age. Personally, I don't prescribe both these treatments, but many patients come to me already on them, and I may or may not continue them. And then calcitonin, I don't think I've ever really prescribed this more than 1 or 2 times in the past 10 years, but just for completion's sake is important to mention.
Now, this might be a little bit of a tangent, but in menopausal hormone therapy, is there a difference in bone density in estrogen versus estrogen progesterone combinations?
So I think that estrogen versus estrogen progesterone is determined by the presence of a uterus.
No, that's fine, but does it make a difference in the bone density?
So I'm not familiar with that
Because
data.
I would think
I don't
estrogen
know.
is the part that really helps with the bone density, not the progesterone could be equal, but if anybody in our audience knows, please let us know or type it in the.
So these are important adjuncts to osteoporosis treatment: calcium, vitamin D. You can get the calcium in your diet. That's always preferred. 4 servings a day in the diet. But if people aren't able to do it in the diet, you could definitely consider calcium replacement in the form of supplements. Also, weight-bearing exercise is very important adjunct therapy.
Just as a side note, I have a dot phrase. I downloaded the National Osteoporosis Foundation list of calcium-rich foods and beverages. If anybody wants that dot phrase, just look at my dot phrases. It's there for calcium sources. And that seems to be helpful because there's lots of foods that are calcium fortified now, particularly for our patients who are avoiding dairy.
Yes, thank you very much for that important point. Yeah, because many people are lactose intolerant, and there are calcium fortified foods. So going back to the guidelines from JCNM, there is a nice chart that can kind of, based on their evaluation of their 107 randomized control trials, they put together kind of with the relative risk of these fractures, which I think was a nice summary. So as we kind of move towards the future, I did want to mention that there are new techniques that are going to help us kind of figure out which patients are going to fracture. One is a trabecular bone score, which is related to gray level textural metric that can be extracted from the two lumbar spine DEXA images. So it can help predict fracture risk. It can help see if the treatment is working. And it's really an emerging technology. Peripheral QCT of bone microstructures, another evolving technology. Going back to our kind of unfortunate approach to osteoporosis, I think fracture liaison services have a very nice role to play for more aggressive treatment of osteoporosis and our osteoporotic patients. And these services can match up patients from orthopedics service with their fractures into our clinic or other clinics that deal with osteoporosis, like women's health, rheumatology, geriatrics. I think with the virtual visits, maybe more people can also get treatment for this.
Can you talk a little bit about the fracture liaison services that we have at the clinic?
So that is easy to discuss because we do not have one. But we are in the process of making one. And as of like a week ago, geriatrics has committed to evaluating our patients in the orthopedics clinics and in the orthopedic service and the inpatient admissions, and kind of getting these patients lab evaluation, bone density set up, and so that they can then be triaged into our clinic or rheumatology.
That's great. I think that will really improve pharmacological management of this. I do believe we are missing a lot of patients who never come over from
So
there.
Leila probably won't talk about this, but you've been working on this for years.
Yes,
You partnered with one of our colleagues in internal medicine, and this has been an attempt across the enterprise with several different groups, and I think you have really championed this and really have made steps forward. It's hard because it takes dollars to get these to move forward, and it's truly multidimensional. Anytime from coming into the ER to being referred to, we need a lot of involvement and a lot of people on board. So I thank you and applaud you. This is would be a huge step forward for Cleveland Clinic.
Thank you very much. So I did want to just conclude by showing a picture of my cat. And unlike my kids who have been essentially homebound since March, my cat has had an improved quality of life. She's successfully transitioned from being a solely indoor cat to a predominantly outdoor cat. And he has been one of, I think, the few living organisms who have tremendously benefited from COVID. But Samaj just wanted to remind you to place your ballot and do your civic duty. And I think there is time for questions, so thank you.
Thank you, Dr. Khan. That was an excellent presentation and a wonderful ending. I think that's a great overview of osteoporosis treatments with the emphasis on the newer drugs that are coming out. I think the fellows would really benefit from this. I believe, Dr. Lakada, you have questions and comments?
Thank you. Is the microphone working?
Yes.
Okay, great. A few comments. Let's talk about the definition of fragility fracture that was started the lecture, which was a very, very good, excellent lecture. That definition, I think, has to be taken with a little bit of reservation. I think clinical judgment should supersede any kind of definition like this. Because if somebody cracks a bone or breaks a bone by sneezing, or by being given a hug, or by having their grandchildren run up to them and hold and wrap their arms around their legs, and they break a bone, that's a fragility fracture. The definition here, I think, is a little misleading. I've had people breaking their wrists by trying to open up a bottle. I've had woodworkers breaking their ribs by pushing on a drill. So The circumstances surrounding a fracture should be investigated and really try to understand what the patient is talking about, and don't necessarily rely on this kind of definition, which so many people still do. The FRAX tool is an interesting tool because this got a lot of the thought leaders around the world trying to develop a way of predicting fractures at an individual patient level. All fracture prediction is driven by population statistics. What this tool is trying to do is to get some of that population data that's out there all over the world and add to it individual risks associated with the individual patient sitting in front of you. And that's what it tried to do. And one of the reasons that drove this development was a lot of young people were getting bone density measurements taken when they were 30, 40, and early 50s, and they came up with low bone mass. And so they started to be overtreated, which got a lot of people concerned because it made no sense, because younger people, despite what the bone density value may be, their risk for fracturing is virtually zero. An older person with the same bone density as a 30-year-old will fracture, but that 30-year-old doesn't. And that kind of got everybody else thinking. And that's how the concept of bone quality started to creep into the notion of osteoporosis. There's something more than density involved. There's something unique to the individual that makes them more susceptible. And that's what FRAX was trying to do, come up with the individual risk factors that might contribute to fracture. And even then, I still don't understand what a 10-year fracture risk means. I mean, does that mean you're going to break a bone tomorrow, 2 years from now, 5 years from now, 11 years from now, 10, 12? You know, there's a lot of questions here. And I think as you start going through your medical career, that is the fellows, you're going to start asking questions and really challenge some of this information. An interesting paper just published this week looked at the fracture risk over 2 years, 5 years, and 10 years using this tool. And what they showed was that statistically, you're able to identify more people if you wait 10 years than if you wait 2 years, than if you wait 5 years. So again, it's a population-driven tool. Clinical judgment still needs to be used. You just can't rely on this 100%. The ONJ story is kind of interesting. We were one of the first centers to publish something about this. It all derived from oncology and using zoledronic acid to treat and prevent skeletal metastases. So what they found is that if you give zoledronic acid every month for years to patients who have cancer, they get this horrendous medical problem called ONJ. But we never realized what we were saying about it. If you give somebody monthly bisphosphonate for cancer, you're giving them equivalent 12 years worth of osteoporosis treatment. Osteoporosis treatment with these intravenous drugs is once a year. You're giving these patients with cancer 12 years worth of that treatment, maybe 24 years, maybe 36 years worth of treatment. So it makes not a great deal of surprise that people can get into this ONJ system, or problem rather. But in the routine clinical use of the drug, it's a very rare event. And the fact that it's not in the news very often, I think, is a testament to the fact, to be perfectly cynical, that the legal profession has found other ways to make their financial gains rather than concentrating on this. Denosumab. This is a... I'm sorry, I missed that one. Say it again.
I think that's background noise.
Okay.
Yes, someone had a slight comment, I didn't hear it.
Okay, go ahead, Dr. Leila.
Denosumab is an interesting medication because it's the only anti-resorptive drug that produces a linear increase in bone density the longer you use it. Every other drug we've had, the bisphosphonates, calcitonin, SERMs, et cetera, their anti-resorptive effect is maximal at about 3 years. The rise in density stops after 3 years or slowly rises. And even after 10 years, you don't get a lot of gain by using these other drugs. So there's a benefit to using denosumab, irregardless of how inconvenient it is, because there's something more to it than these other drugs that we've been using for years. Glucocorticoid treatment. I have a tough time with this because the longer a person uses a glucocorticoid, the more dangerous it is to the skeleton. The glucocorticoids during the first 6 months of use stimulate bone turnover. And you can see that with the rise in the anti-resorptive markers. The longer you use it, the lower these resorption markers start to decline. But what I'm saying is that short-term effects of glucocorticoids stimulate resorption. Long-term effects of the glucocorticoids poison the osteoblasts. So that's contributing to bone problems. So then on top of that, you're going to use an anti-resorptive drug in a patient who may be compromised already by a glucocorticoid. And quite frankly, I don't know how long to use these drugs because of that potential complication. Those were the striking things that struck me as I was listening to this. And anybody have any questions, be happy to chit-chat back and forth. I think you got a few minutes left.
Thank you, Dr. Licata.
Angie, this is Dave Schumann. Can you hear me okay?
Yeah, Dave,
Yes.
how you doing?
Hi, I'm doing great. I was just listening to your comments about the FRAX tool and wondering about the tool that we had, 20 years ago, that we called Fracture Calc, that was based on a model that was in Journal of Clinical Densitometry.
Right.
I think it was in the first edition,
Right.
where we did another approach instead of FRAX that I thought had a better refinement of who should and shouldn't be treated. Do you think there's any role for that, or whether FRAX has done a good enough job of delineating who needs treatment?
Well, in my personal opinion, there's a lot of politics involved in this FRAX stuff. But
Yeah.
there are 5 fracture risk prediction tools out there that
Okay.
have very significant use around the world. One is germane to Australia. There are some germane only to the population in Europe and specific countries there, but they are useful tools. And you can basically use these tools to assess the risk during an office visit by asking certain questions. So indeed, there are other ways to do this, and I would suggest the fellows look this up because there are publications out there within the last couple years that talk about all of these things. And indeed, there are other ways to do this. FRAX, I will say that FRAX has added another variable to their list of variables, and that's the trabecular bone score. By throwing this into the mix, what they're trying to do is to come up with a more precise estimate of the individual patient's risk of fracture. I think medicine has come a long way in using all of this information about risk in a more precise way for patients. All of medicine, all the data we use, everything we talk about, lipid risk, cardiovascular risk, diabetes risk, et cetera, are population driven. When it comes to the individual patient, I have no idea how to use this information in an accurate fashion. Medicine is now recognizing that there are individual idiosyncrasies to a patient which make them at risk for various diseases. That's where molecular medicine is going, and I really applaud that. Hopefully, I'll be alive long enough to see this really come to fruition. But
Amen.
the FRAX tool is still a population-driven thing. Doctors need to use clinical judgment still to assess whether a patient needs treatment. FRAX may be a tool of an individual patient that shows no risk, but if there's a suspicion in the clinical history that something's going on, you just got to forget all of that stuff. But the bottom line is there are other tools out there that can be used besides FRAX.
Thank you, Dr. Licata. I believe I had asked a question about postmenopausal hormone therapy, whether there was a difference between estrogen, progesterone versus estrogen only. And I think, Dr. Licata, you mentioned no, there's no difference. I believe Dr. Al-Haj has a comment here.
So I'm not sure how this relates to postmenopause, but I know in premenopause, I don't know if anyone can hear me.
Louder.
Talk louder.
So in premenopause, progesterone causes a reversible reduction in bone density, progesterone hormone.
Right.
That's why for estrogen progesterone, but I don't know how that relates to postmenopause.
Well, both of them have a capacity to make bone look better on a density test. And the data published years and years and years ago show this to be the case. But I think if you're talking about premenopausal people who are having problems with bone density, you're probably talking about specific diseases like anorexia. You're not talking about an estrogen or surgical menopause, correct?
But no, I'm just
I was just asking postmenopausal
Yeah.
surgery or natural menopause therapy, but Dr. Al-Haj was just talking about progesterone in terms of premenopause birth control.
Yeah. Keep in mind that this notion of, well, let me back up a little bit. I'm not sure what osteoporosis means when people talk about it, to be perfectly honest with you. Some people think it's merely a low density. Other people are saying it's a low density in combination with, quote, fragility fractures. Other people will say it's low density microarchitectural destruction. And the reason I say this is that, the widespread use of densitometry has caused us to see that a lot of young individuals, both men and women, in their 20s and early 30s have a low bone mass. But is that bone mass susceptible to fracturing? Well, it probably is as they get older, but in their 20s and 30s, this probability of fracturing, even with a low bone mass, is very low. And there's a lot of clinical data to support that. Age is an independent predictor of fracture risk. The older you are, the more risk you have for fractures. And that was really shown over 30 years ago in studies looking at bone density measurements in people who were in the age group of 20 to 30, 30 to 40, 40 to 50, et cetera, et cetera, et cetera. And what they found is that a similar bone density in a 20-year-old or 30-year-old has virtually no fracture risk, but that same bone density in an 80-year-old has enormous fracture risk. And so therein lies the distinction and the conundrum about what do you do with somebody who has a low bone density when they're younger? Well, part of that has to do with their inherited low density, most likely. Some of it may have resulted from poor growth and development for a variety of reasons. But they inherently probably don't have that destruction to bone that you see in the older age group. And so therefore, giving these drugs, giving these youngsters anti-resorptive drugs probably makes no sense. And so when Dr. I think Al-Haj is talking about using progesterone, well, that's one of the things that people have tried in the younger age group to see if it did any good, to improve bone density. And it may very well help. Exercise, good nutrition, calcium, vitamin D is probably the preferable way to do that. And we published a paper decades ago looking at a group of women over a 5 to 10 year period of time, looking at their bone densities at the beginning and looking at the bone densities at the very end. And what we found was that those individuals that had a low density in their 20s and 30s, 10 years later, had a low density at the same level. So they weren't losing bone. They probably never had bone mass equivalent to what other people may have, but it intrinsically is healthy, strong bone, regardless of what the DEXA is showing. But keep in mind that DEXA is a two-dimensional imaging technology, and you see that from the pictures of the scan. It's a two-dimensional scan, X origin, Y origin, but what we don't recognize is that picture is actually three-dimensional. It goes into the paper. There's a three-dimensional architecture there, which is critical to strength. And you're not seeing that on the scan, and that leads to a lot of the conundrum of trying to figure out what's going on with these young individuals.
All right, unless anybody has any other questions, I think we can, oh, Dr. Feynman, sorry, you had your hand raised. Dr. Feynman? You'll have to unmute yourself. That went away. Maybe he lowered his hand.
Sorry about that. Yeah, I'm on now. Thanks very much for a great presentation. I have one comment, one question. Nobody has talked about how you prevent falls in the older population, or whether we should be recommending hip guards, for example, in older women. This, to me, is a simple thing. No drugs are involved, and we may be saving a hip fracture or two along the way. That was the comment. The question I had is Smudge voting live or voting by mail?
He did early voting in person, which only took 15 minutes.
Great, thank you. Keep safe, folks.
Can I address the hip guards? There was actually studies looking at hip guards predominantly in long-term care facilities. They are historically have been very cumbersome, and so compliance with those is tough, but they are effective. In terms of fall prevention, I agree, and I think that's one of the places that we need to remember that physical therapy is excellent at doing balance and strength care for our patients, particularly those who are at risk. Checking that vitamin D level. We know chronically low D levels have a lot to do with proximal weakness. And so I think that's part of the total care. We need to keep an eye on that.
And doing yoga and Tai Chi and also other exercises can really help balance. So if someone is to fall, they can more likely prevent fracture, fracture like an overfall to the ground.
One of the things that, can you hear me?
Yes.
Yeah, one of the things that we developed, I don't know, with a student like 10 years ago, I think the Rehab Institute is you can screen for fall risk in one way in the office just by having your patient try to stand on one leg for 5 seconds. If they can't do it, their risk of falling is increased, and you can try to refer them to physical therapy for programs to try and address it.
Wow, that's a really cheap and easy way to help. So thank you for mentioning that. I should add that to my evaluation.
Thank you so much, everyone. Thank you, Dr. Khan, for that wonderful presentation, and we will see you next week.